Good morning. Thank you so much for this invitation. It is a pleasure to be here presenting in this press briefing. My name is Andres Zorrilla. I'm an anesthesia resident at the Brigham and Women's Hospital, and today I'm going to present a study entitled Sustained Reduction of Opioid Prescriptions within an Enhanced Recovery After Thoracic Surgery Program. As everyone knows, ERAS programs consist of a multidisciplinary, evidence-based perioperative care pathway that were originally designed to hasten recovery. However, recent studies have shown that ERAS implementation plays an important role in reducing opioid prescriptions after hospital discharge. Multiple studies, especially quality improvement studies, have shown a reduction by approximately 50 to 80% of opioid prescriptions after ERAS implementation. And this effect has been explained by the use of multimodal analgesia, the increasing use of minimally invasive surgical techniques, and the rapid mobilization and recovery. All of these components are typically part of the ERAS protocols for thoracic surgery. However, these studies have been limited to only 4 to 6 months of follow-up after ERAS implementation. Therefore, our objective was to determine the impact of ERAS implementation on discharged opioid prescriptions at long term after thoracic surgery. We conducted a retrospective study including all the patients within our 4-year ERAS program, and as a result, overall we included a total of 2,081 patients. In this table, we describe the demographic and clinical characteristics by each year of ERAS implementation from the first to the 4th year. As we can see, the average age of the population was 60 years, and most of the patients were classified as ASA physical status greater or equal to 3, with approximately 88%. 10% of the patients had metastatic disease, and the use of minimally invasive surgical techniques was dramatically increased during the study period from 34% during the first year to 46% during the 4th year. Importantly, the compliance with multimodal analgesia remained constant at 80% throughout the study period. It is worth noting that our multimodal analgesic protocol included pre-op gabapentin, pre-op tramadol, intraoperative acetaminophen, posterior intercostal nerve block with liposomal bupivacaine, intraoperative ketorolac, and postoperative celecoxib and acetaminophen. The most common type of lung resection was lobectomy, followed by single wedge resection. And finally, at the bottom of this table, we can see a dramatic reduction of discharged opioid prescriptions from 197 morphine equivalents during the first year to 124 morphine equivalents during the 4th year. Also, we evaluated secondary factors within our ERAS program that were potentially associated with lower opioid prescriptions over the study period. Interestingly, we found that opioid prescriptions are reduced by 11.8 morphine equivalents by each year of ERAS implementation. Also, we found that opioid prescriptions are reduced by 84 morphine equivalents with the use of video-assisted thoracic surgery compared to open surgery. And additionally, the use of robotic-assisted thoracic surgery reduced opioid prescriptions by 139 morphine equivalents compared to open surgery. Also, opioid prescriptions tend to increase by 1.3 morphine equivalents for each unit of morphine equivalent administered intraoperatively, and also tend to increase by 1.4 morphine equivalents per each unit of morphine equivalent administered postoperatively. Another factor associated with lower morphine equivalents at discharge was the dose of acetaminophen after surgery, having a reduction of 18 morphine equivalents per each gram of acetaminophen administered postoperatively. Finally, as a conclusion, there was a 50% reduction in opioid prescriptions after 4 years of ERAS implementation in our institution. The use of minimally invasive surgical techniques facilitated further opioid reduction within our ERAS program, and lower administration of opioids during surgery is associated with reductions in opioid prescriptions.
Hi, my name is Rakesh Arora. I'm a cardiac surgeon and intensive care medicine specialist at the University of Manitoba in Winnipeg, in Canada. I'm also the chair of the Society of Thoracic Surgery Workforce on Critical Care, and the co-chair for this year's Perioperative Management and Critical Care meeting. I would also like to take this opportunity to thank Dr. Michael Grant, cardiac anesthesiologist at Johns Hopkins, who also provided content for this particular video. Enhancing recovery after surgery has been an extremely important and disruptive topic, and I mean disruptive in a good way, to the field of cardiothoracic surgery. A comprehensive program of enhancing recovery after cardiothoracic surgery looks to target improvements during the patient's journey, both before their operation, during the after phases of the particular procedure. Developing processes that improve the patient experience through this entire surgical journey, and importantly, also improves patient flow through the healthcare systems, are the goals of an enhancing recovery program. This perhaps has never been more important than it is at present, due to the surgical backlog that has been generated by the current pandemic. One area that has gained a lot of attention recently has been developing new effective management of discomfort following heart and lung surgery. Traditionally, the use of opioid medications, also known as narcotics, which includes agents such as morphine, acetaminophen with codeine, and other similar drugs, have been the mainstay of how we treat post-operative pain. While these medications can provide good relief, over the past few years, several studies have shown that more than 10% of patients can suffer new persistent opioid use, defined as repeat prescriptions in the first 3 to 6 months following their surgery, and otherwise opioid naive patients, or in other words, patients who have never had these agents before. As a result, there is significant concern about long-term use and perhaps addiction with the use of narcotics in the post-operative period. As a result, several cardiothoracic surgery programs have now demonstrated that using a multimodal approach to surgical discomfort after their procedure can be achieved and result in a significant reduction in the reliance on opioid medications. One of the abstracts of this year's meeting provides new information on this issue of post-operative opioid use following thoracic surgery. Importantly, look not only at the targeted use of a multimodal plan while in hospital, but also paired this with key prescription guidelines to reinforce and sustain outcomes after hospital discharge. This is an important finding and exciting one that will hopefully be emulated by other programs going forward. Look for this paper and many other engaging and informative content at this year's meeting. Thanks very much.